So what's hypnosis? Just like Dr. Felicia explained, pharmacological approach is always the main route for any pain management. Any other methods is an adjunct to that pharmacology. We have a very good pharmacological system which is well developed and is still being developed to minimize the side effects and to increase the comfort of the patient. So here I'll be talking about hypnosis. Let me share a video with you how hypnosis is being done. Hypnosis, there's a myth surrounding hypnosis. The myth is a person uses a watch, dangles a watch and knocks you off, makes you unconscious. That's what the media portrays. But in medical hypnosis is totally different. I'm fortunate enough to have the ability to provide this service to some of my patients in the operating room. So there's a video here about a patient who is about to go through a hand surgery. She has a fungating mass in the hand, but pain is one factor, but the emotional trauma relating to that pain, it's also there. And also she has few previous side effects secondary to general anesthesia. So going through another general anesthesia for her would be an uncomfortable experience. So this is where hypnosis came about for her. So let's briefly see this video, how I do. So let me run through with you how is it done. So if you see here in the video, I'm asking her to focus on her hand. So the hand focus sensation is part of the hypnosis, how is it done. And from this, what happens is the patient relaxes further. And while relaxes, sometimes not all patients will experience some amount of emotional, they go through emotional journey, they cry. So in this patient, she cried. And this cry actually makes her feel comfortable, relieved that someone's listening to her pain per se. So this is how she looks like under hypnosis, and there is no other medication used for this surgery except for nitrous oxide and oxygen. So let me go to the next slide. So what's pain? So pain is defined by the International Association for the Study of Pain as unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in such damage. So there's broadly, we can describe pain as two, acute pain and chronic pain. So acute pain, we all know, is an important warning sign, normal and natural biological response to noxious stimuli. While it lasts temporarily, with or without any physiological stress. And we are here to talk about chronic pain. Chronic pain normally lasts slightly longer, 3 to 6 months or longer than that. It serves no biological purpose, physical or psychological causes. It causes a lot of psychological cause. There's no clear trigger, may not be associated with any diagnosable condition. Most of the time it involves CNS changes. For example, chronic pain involving the hand, maybe there might be muscular dystrophy or muscle wasting. So pain is an enormous health problem, both in terms of suffering and financial costs. Conventional medical treatments have limitation in treating chronic pain simply because patient varies from response to various kind of medication. That is why patient needs to be seen by oncologists or even palliative doctors to have their medication tapered to the best level. Pain has a sensory component which is rated as 0 to 10, or an emotional evaluative component, which some of them describe as this awful component. Acute pain is time limited and associated with tissue damage due to injury and illness. Chronic pain is very complex. There are many psychosocial factors exacerbating those pain. So in this article in 2014, hypnotic approaches to chronic pain management, it was summarized as hypnosis could assist in acceptance rather than changing the pain itself. So examine pain from a distance, accept notion that all perceptual experiences are temporary. So what I'm trying to say that hypnosis does not remove the pain, but rather it changes the patient's perception on the pain itself to make it more acceptable. In this paper, 2006, pain and pain-related sufferings can be the end result of a number of factors: maladaptive coping patterns, inactivity, sleep dysfunction, depression, anxiety. Focusing on pain alone is an effective way to address all the negative effects. In chronic pain, there are many other components need to be tackled. Pain can be managed pharmacologically, perhaps psychological approach needed for other approaches, like other issues like depression and anxiety. In this, several authors have described that a typical source of contention in the hospital setting is for the healthcare professional to observe a minimal wound or injury to conclude that the patient should not be hurting so much. So current research have documented that the patient's perception of his or her own pain should never be diminished. In this paper, 2009, hypnosis is effective for acute and chronic pain. Hypnosis is more effective than medication, physiotherapy, education, or neurofeedback alone in this paper. So in this paper, titled Cerebral Activation During Hypnotically Induced and Imagined Pain, 2004, what they found that when brain activation is compared during functional MRI between the experience of physical pain, hypnotically suggested pain, and imagined pain, what they found is similar activation patterns are found in physical and hypnotically induced pain. Hypnotic suggestions show the different brain area are activated with different suggestions. For example, reduced pain sensation produces reduced activity in the somatosensory cortex, while pain won't bother you, produces less activity in the anterior cingulate gyrus. This is anatomy part of the brain. When a paralysis suggestion is given, brain changes occur, similar to patients with convulsion disorder involving leg paralysis. This is what documented in this paper. So in pain gate control theory, we all know that pain can be modulated, it can be derailed, it can be enhanced or suppressed as soon as they enter the dorsal horn and begin their journey to the brain. So I'm going to share a video here. It's by a prominent doctor in Stanford University, replacing opioids with opioid.
There's been a prejudice in modern medicine that the only real interventions are the physical ones, ingestion, injection, or incision. But this doctor is pointing toward a powerful therapeutic tool that is underutilized, the human brain. Using a technique called self-hypnosis, we can teach people how to powerfully use their brains to control the way their bodies feel and function. What is hypnosis? Well, an example comes from the Sochi Olympics, where unlike here in Davos, there was barely enough snow for them to ski on. They were only allowed to do one practice run. So what the skiers did, this is Bode Miller, would stand next to the course, look up, close their eyes, take a deep breath, and imagine every move, every turn, and it worked extremely well. The team got many medals. The field of hypnosis began with the Viennese physician Franz Anton Mesmer in the 18th century. I have used hypnosis with some 7,000 research subjects and patients, and have devoted my career to studying what happens in the brain and how well hypnosis works. Hypnosis is a state of highly focused attention. The skiers at Sochi were just focusing on where they put their skis and how they move their bodies. That means dissociating other things that would ordinarily be in consciousness, fears about competition and competitors, for example. It also involves suggestibility, suspending critical judgment, so you don't judge and evaluate, you just do. We decided that to make hypnosis widely available, we had to understand how it worked in the brain. We studied people who are highly hypnotizable, not everybody is, and found that they had coordination in their brain between their executive control center that plans and does things, and a part of the brain that engages in conflict resolution and decision making. In fact, when we hypnotized people in the scanner, we found that we turned down activity in that brain region, which is also part of the pain circuit in the brain. So you spent less time worrying about what you were doing and more time just doing it. There are two other effects in the brain that we see when we hypnotize people. One of those effects involves linking the executive control region to a deep part of the brain called the insula that is involved in brain-body control, in pain and anxiety perception. So you have better control over your body function and perception. But we disconnected the brain from a part of it that is involved in self-reflection. So you no longer worry about what you're doing, you just do it. We Americans are in a lot of pain, as are people in the rest of the world, as you heard from Beth. 1 out of 3 Americans has an opiate prescription. The rate of accidental drug overdoses has tripled since the year 2000. 64,000 people died of it last year, twice the number of people at the peak of the AIDS crisis of car accidents. So it's a terrible problem. By contrast, hypnosis doesn't kill people, it doesn't addict people, but it does reduce pain. This is a randomized trial trial of patients undergoing medical procedures. The red line at the bottom shows you that the hypnotized patients had 1/5 the pain. They used only half the medication. They ended their procedure 17 minutes earlier than the other patients. But does it last? We did studies with women who have metastatic breast cancer. We taught them to form bonds with one another, face the illness they had to face, and do self-hypnosis for pain. By the end of the year, the green line, they had half the pain that the control group did on the same and very low amounts of medication. The biggest surprise of that study was that after the study we thought had been finished, we followed up on what happened to the patients. And it turned out that the patients taught this self-hypnosis and group support lived 18 months longer than control patients on the same kinds of medical treatment for cancer. By 4 years after, all the controls had died. A third of the treatment group were still alive. We're now using a new technique, repetitive transcranial magnetic stimulation, a highly focused magnet, to create the same kinds of activity in the brain that we observed in hypnotized subjects, to enhance the hypnotic capacity of people who are less hypnotizable, and we're using it to treat fibromyalgia syndrome. Modern research has shown us how the brain regulates the body, how it feels, and how it functions. It changes metabolism, it changes pain, as you've heard, and it may even affect survival time. So in health, it isn't just mind over matter, but mind matters.
So what you focus on, you amplify in your awareness. So in medical practice, the words that we say to patients are very important. So the words does have some certain impact on patients. So everyone can and able to use hypnotic language, influence the patient in a positive way, just like how media does. Media does influence us in many ways. So these are some of the approaches, some of the language patterns that I as an anesthetist use. For example, that when I give my spinal, I would say something like, if you get sick and get nausea or vomiting, it can be treated. This is one common way that we talk. But instead of doing this, we can perhaps give you medication to help you feel like eating and drinking as soon as you feel like it. So what I'm trying to say here is the common language that we speak does explain the issues that we want to convey to the patient, but sometimes it creates certain unwanted anxiety. So perhaps we can change our language, the way we talk to patients, to make them feel more comfortable. For example, you just have to learn to live with it. When we talk about pain, perhaps you can change it to, you can find ways to live your life. It may hurt when you bend over, for example, or perhaps you can see something like, you may feel it stretch when you bend over. So how else can we refer to pain? For example, instead of telling this problem that you have can be very painful, we can use the word discomfort, less comfort, uncomfortable, levels of comfort. Components in pain, in hypnosis involving pain care, which can be utilized by any doctors. First, listen to patient's description of pain and all its aspects, the clinical aspect and non-clinical aspect. Look, pay attention to patient's body language. Accept pain is a subjective experience, so do appreciate patient's description of his or her pain. Use patient's perception of pain to reduce comfort, reframe and suggestions. So normally, what do I do? Strategies with hypnosis that I employ with my patients: pain control, relief, hypnotic analgesia, anesthesia, symptom management, emotional detachment for the physical sensation, coping with procedures for investigation. For example, some patients are very needle phobia or MRI phobias. Promote self-management, reinforcement strategies, and accepting their pain, teaching them how to accept their pain better. Sorry, I'm going through very fast. So this is my last slide. I'm going to show you, this is a patient I managed to serve. He has to go through an eye surgery. He has a fungating mass intraocular that's causing him partial blindness. He's a very young gentleman, 33 years old, and he has severe allergy towards lignocaine. Normally, most of the eye cataract procedures is done with topical anesthesia, but this patient has allergy to certain medications. So general anesthesia can be difficult, local anesthesia can be difficult, and we utilize hypnosis and an approach, and this is the video of how we use it. Basically, I get him to focus and bring him to a state of hypnosis. Once he's hypnotized and he feels a comfortable state and he enjoys the experience, I just double that sensation further and further, and then re-practice the skills again with him. And once he's comfortable with it, he's confident with his self-hypnosis skills, then we bring him down to the operating room. So he's asleep now, he's comfortable. So in the operating room, this is how it looks like. Again, we go through the same process, induce the self-hypnosis, bring him again into that stage, help him to be in that state. And once he's truly comfortable, look at his neck posture, then the surgeon will do the surgery. So in this case, everything went well. So thank you very much. That's all I have. Perhaps I can pass to Dr. Sanjeev and to the audience. Anything that you would like to ask or share your experience with us?
Yeah, hi everyone. Thank you so much, Dr. Anand. And we will have Dr. Anand Chandrasekharan and also Dr. Felicia Chang now. And we will go to the Q&A section. So everyone, do not worry about your CPD points. We will be contacting you to get a 1 CPD point. And now we'll go to the Q&A section of this section, and we have a question here for Dr. Felicia. The first question by Dr. Azlini, and Dr. Azlini asked, one second, I'm just trying to get it. Yes, Dr. Azlini Binti Ahmad, thank you so much. She's a practicing general practitioner, and she asked, what drugs can be given for patients due to cancer at the GP or general practice setting?
All right. Thank you for the question, Dr. Azlini. I think in the GP level, you have very limited. You have a lot of NSAIDs, but you do not have a lot of opioid. But one of the very things that you have to, as my slide has shown you, you have to find out the source of the pain. If the pain is related to bone or musculoskeletal, it's quite safe to use NSAID, but make sure they don't have history of gastritis. Then you can actually cover with PPI. But if you think that the is tumor related, and you can start off with Ultracet and Tramadol, because this is something that you can acquire as a GP. You cannot get opioids in the community, but you can actually start with Tramadol. Start with 50 milligrams 6 hourly, okay, and then you reassess after 2 to 3 days. You can go to 100 milligram QID, and if it doesn't help and then the pain doesn't goes away, you need higher opioids. For example, you need morphine. Then it's time to refer to palliative care or pain team in the hospital. So you can always refer to me. If it's cancer related, I'd be happy to be able to help, and I'll communicate with you once I started with opioid to how to titrate it. You can help to titrate in the community.
Yeah, thank you, Dr. Felicia. We got another question here by Dr. Jamila Zainuddin. Thank you so much for your question. And the question, I guess, will be for Dr. Anand. Since pain is very subjective, does Type A personality do they feel more pain versus the non-Type A or Type B person? How would you handle it, Dr. Anand?
Oh, sorry. So it's a very good question. Thank you. Some studies have quoted that, but I can't remember offhand which studies are there. So type of personality does influence type of the pain the persons perceive. So how would I manage? Number one is I would actually talk to them. What are their concerns? Regardless what type of the person is, whether type A, whatever type personality they are, everyone has their own individualized concerns. So managing their concern helps to manage the pain better. Individual A may have a different concern, even though same type personality. Individual B, same type personality, has a different concern, different responsibility, perhaps different baggages they carry. For example, a toenail for us may seem very insignificant toenail pain, but for them it may be in the scale of 10, and it may be troubling, worrying their children's education, for example, that responsibility. So how do I manage them is basically taking time to talk to them. Yes, it takes lots of time, but I think that is part of our work. A pharmacological approach is definitely a pathway here, or non-pharmacological approach also. But then before we consider what treatment we should give, spending bulk of our time in understanding the pain helps a lot. So I hope that answers the question.
Yeah,
Thank you.
thank you so much, Dr. Anand. I think there's a paper of a local general hospital over here in Malaysia is talking about the different races and how it affects different types of pain, which they said that it was multifocal or multi origin. Anyway, we got another question here by Dr. Santiago. And Dr. Santiago's asked, maybe Dr. Felicia can answer this because at the moment in Malaysia, we have a problem with the use of opioids and dependency and also addiction. So he asked, general practitioner Dr. Santi, he asked, some patients demand injection, IM injection of pethidine rather than tramadol. I'm worried about addiction. He doesn't want to go to hospital because of cost. So Dr. Felicia, would you like to answer that?
All right, thank you for the question. I think opioid is actually not only in Malaysia. A lot of countries, we are very fearful of using opioid. You know, America, we have issues with opioid overdosing, and we have issue with a lot of abuses. I think it doesn't appear only in America, but I think in our own country, we have a lot of fear as well. But I think it's just because people do not understand the usage of opioids, and people are very fearful. I think one of the things that I've realized is a lot of my GP friends are very fearful of using opioid. I guess it's because of the understanding and the accessibility of the medication. We were not trained, seriously. Before I was in palliative care, I was never trained in using opioids. So I think understanding the pharmacology, pharmacokinetic of the medication actually helped to relieve some of your fear. And how do we address public? You know, as long as the doctor is fearful of using opioid, the public will always be fearful. So opioid fear is always there, phobia is always there. It is our role to dismiss some of this myth of addiction. If a patient have pain, they will not really get addicted because the pain will take away all this discomfort in their body. So titrating the medication is important. Not using polypharmacy is important. So let's come to the question of injectable, pethidine and injectable tramadol. When I was studying under Dr. Mary Cardosa, she's the first pain specialist in Malaysia. I was under her teaching in Selayang Hospital. She hated pethidine because of all this. No, pethidine can actually increase the risk of seizure in a patient. So she actually wanted to ban pethidine in Malaysia, but because it is a very quick and effective way to deal with pain, so a lot of patients actually have been hopping to different hospitals to get pethidine injection. So for me, how do we address this issue is actually find out what is the cause of pain. Is it a psychological need to have the pain, the pethidine? Or is it related to a physical problem, or it is related to a disease or a condition? So have to deal with the source of the problem, which is if it is psychological, I think they need psychiatric help. If it is related to physical or it is related to pain, then a pain specialist will be able to help to address. My advice to GP is don't keep on injecting them. Because they will be hopping to different clinic kesihatan, they'll be going to different GP for this pethidine injection, and we do not have a centralized data that where they go. So for me, it's like reject them, send them to the appropriate pain specialist, especially chronic pain specialist. We have, I think, if I'm not mistaken, Selayang and different hospitals, they have this team that deals with chronic pain through psychological, through lifestyle changes, through perception and all that. So I think don't give it to them, understand them, find out where are they coming from, and then refer them to appropriate group or team. I hope that answers your question.
Yeah, thank you, Dr. Felicia. The next question by the same general practitioner, Dr. Santi, he asked, for pain, can I start them with sedatives like Ribopam 1 mg or 2 mg?
Okay,
are you familiar with that? Yeah.
I think Rive is like a diazepam. I think there's a lot of benzodiazepine outside. Benzodiazepine is very good if you have a pain related to muscle stiffness and if the patient cannot sleep at night. But at the same time, we do know benzodiazepine has a risk of addiction over time, dependent over time. So unless your patient is a stage 4 disease, it's a very chronic disease, you have to be very careful when you start your patient on benzodiazepine. Same principle, go back to the pain history, find out where is the source of the pain, what is the source of the pain, and treat it appropriately with the appropriate analgesia. If your patient comes in just to get the benzodiazepine and say they have pain and you prescribe without understanding a little bit more, then you are just going to create somebody who's coming back again and again for the benzodiazepine, because after a while, it can be addictive.
Yep. So we have another question here, but thank you so much, Dr. Felicia. There's another question for Dr. Asad, and he's talking about, can physical therapy help in pain management for patients with cancer? I think this is well documented that the treatment is a combination of physical, pharmacological, and non-pharmacological. Today we described by Dr. Felicia and also Dr. Anand, and we talked about alternative methods. So it's basically pharmacological, non-pharmacological, and also a bit of alternative like hypnosis. Yeah, so physical therapy does help, and also it helps with dealing with patients with osteoporosis, and also the prevention of DVT in patients with cancer who are at high risk. Yeah, so we go to the next question, Dr. Azad. Thank you so much for the question. Is hypnotherapy as pain relief accepted in hospital settings? I think Dr. Anand, do you have any experience with this? Because in Malaysia, but the next question also by Dr. Raghunath, is there a center that in Malaysia that has this kind of training? I think my exposure to this field is limited, so I'll get Dr. Anand to explain about that.
Thank you, Dr. Asa, for the question. Answer to is hypnotherapy as pain relief accepted in hospital setting? Answer is yes. Again, when a person walks in with pain, the primary doctor needs to be consulted first. So my hospital, I'm an anesthetist. So as an anesthetist, I do use pharmacological as my first approach. If the patient is not suitable for pharmacological approach for whatever reason, whether it's for patient reason because patient is not consented to it, or medical reason, then hypnotherapy or any other approach can be considered. Again, with communication with the primary doctor and the patient himself, because at the end of the day, the patient is the one receiving the care, so they should be well aware of. So the answer to the question is yes, it's accepted in hospital settings, but please talk to your primary doctor. So regarding the second question, is there hypnosis training center, especially for cancer patients and doctors in Malaysia? I think there are a few. Perhaps I think you can Google around. But whether it's in a MOH background, I mean, whether MOH offering of just like how we go through our postgraduate studies, answer is no. But you can look around. Yeah.
So thank you so much, Dr. Anand. So basically, we have we're gonna end our session here. Please do feel free to ask your questions, and our panelists will get to you either on the Doherty platform, and we'll continue to answer you all. And I'd like to thank everyone, our panelists, especially Dr. Anand and Dr. Felicia, for joining us today.